Hello. We're going to get started here in just a bit with the webinar and really look forward to everyone participating, and really been quite fun for us to start to put this together. I see that our participants and such are coming on and attendees, so I really appreciate everyone's participation in this. Just as to begin, I received lots of questions. So if people would like to send in some of their questions and answers, happy to, really go through those with anyone. I know that a lot of people are interested in thyroid eye disease, but we're going to be talking about everything oculoplastics if desired, and also kind of talking a little bit about the state of the art in both oculoplastics, but also in thyroid eye disease, which I know a lot of our members are very, very interested in. So without too much further ado, we'll get started at this point in time. Hopefully everyone can hear me okay, but we're also recording this, and that will make it very, very easy to, to go back and, if you want, share with anyone in the future. So I'm going to kick things off just, with a little explanation about Graves' disease, thyroid eye disease, just because that is really a very current topic. And I think that one of the things to really think about is how this disease occurs, and a little bit of potentially how we can treat it. Because I think as we talk about that disease, which I know people are interested in, we'll also get into ptosis and many of the other things that are very much interested in, on everyone's mind as far as dealing with various aesthetic issues, which I deal with all the time in thyroid eye disease. The interesting thing is that most people want to look like themselves. They don't want to look like somebody else or look like they have had surgery or other things. They want to just go back to the way they were looking before. And so I think that that's a really important component to this. And I think that, one of the things that, we can talk a little bit about, and I'm going to share my screen, is to actually, talk a little bit about thyroid eye disease and, what we can do. So just going to get this started. And again, you're very welcome for recording. For us recording. And what I'm going to do is just kind of show this in a larger screen and screen sharing. So this is just from a little TED Talk. And what I think it demonstrates is just the two fundamental stages that people often think of this disease during an active phase or more of a chronic phase. Now, the fundamental process here is that the immune system is attacking the tissue around the eyes. It's also attacked the thyroid, probably due to a different receptor, which we'll kind of get into later. But it causes this inflammation, and the immune system attacks the tissue around the eyes and causes this tissue to expand. And this is called the active phase. Now, a lot of times I've heard it referred to as the inactive phase, and patients don't really like this because, frankly, there's nothing inactive about this disease. It just means that it's not changing. It doesn't mean that the symptoms have necessarily gone away or that anything has gotten better. It's just that it's not changing. And in the past, we've always thought about trying to treat this disease in the active phase with something like steroids or inflammatory medication, and later in the inactive phase with something like surgery. I think those paradigms are now beginning to change, and we'll talk a little bit about why. But thyroid eye disease, you have inflammation and tissue expansion and remodeling of the orbit. Essentially, the fat and the muscle expand, pushing the eye out. It also infiltrates the muscle, causing double vision. And all this extra pressure behind the eyes really just kind of causes pain, pressure. Often it just doesn't go away, and it's actually quite hard to fix. There are a few things we can do, such as surgery and Botox and even Depezza, but it's very hard. In general, what happens in the immune system is that you have these immunoglobulins, the TSIs, but also other ones that attack the IGF-1 receptor and the TSH receptor. And there's not going to be a quiz later on. It's just knowing that these receptors are kind of the target of the attack. And that's kind of the target of many of the medications that are being looked at for this disease. This targeted activation of these receptors then causes immune cells to come in, and it causes these fibroblasts to proliferate behind the eye and produce something called hyaluron. And that gets within the muscle cells and causes all this expansion. Well, the idea is that if we could take a blocking antibody or interfere in this activation, we might be able to prevent all these downstream reactions from occurring. And I know it generates a lot of the discussion and questions that have been generated have been based upon the drug Depezza. And this is essentially the idea and the concept behind the mechanism of action is that you're interfering at the immune system's target. You're interfering by not allowing the immune system or this receptor to be activated. And that eventually seems to decrease the fibroblasts and decrease the hyaluron and causes this disease to kind of go away. And this was tested in a couple clinical trials looking at Depezza or teprotumumab and given very early in the disease process, and essentially demonstrating that it kind of dampened this curve or returned patients back to a relatively near normal state, much improved. This is just one of my patients who was treated with Depezza, and this was published in the New England Journal of Medicine earlier this year, demonstrating how it really returns the eyes and gets rid of the pressure behind the eyes, that fat muscle accumulation. I also get a lot of patients who ask me, well, what can I do about the bulging of the upper part of the eyelid? And as you can see here, that went away too. Some of that's just due to taking away some of the volume from behind the eye with this medication, shrinking, but also the lower eyelids are less puffy. So you do see a dramatic, usually a pretty dramatic improvement. He didn't have any surgery, so his eyelids came back relatively to normal position without any additional surgery. And just another example that fairly significant impact upon what you see. Now, I'd be hard pressed to achieve a result like this with surgery. I think that would be a really great result. So I think a medication that puts us on the way to achieving that, even if we would need a little bit of surgery later on, is really quite an advantage. And then here's just the MRI where it was pre-treated, where there's and you don't have to be a radiologist to know that the arrow kind of shows that this muscle here is kind of big. And then after treatment, that muscle shrinks. And it shrinks by about half. So it's quite a substantial reduction in the muscle size that you're seeing, really under saying that you're really getting to what this disease is. Now, when we think of surgery, which I know a lot of people have questions, and I'm going to turn to questions very shortly, we want to know that form follows function. Again, the medication makes a huge and dramatic difference, and we're beginning to use it even in the more inactive phase, and I'll answer that in the question session. And it goes a very long way in a dramatic improvement. And patients really want to improve both their aesthetic and their functional situation, and those go hand in hand. Improving function and improving aesthetic just amplify each other. What looks good works well, and that's kind of the idea here. And most patients want to return to, if not improve upon, that pre-disease appearance, and that certainly is possible. And the way I've done that in the past, and certainly in still quite a number of patients, is with a customized deep compression. But it's really customized facial surgery. And that might be looking at the entire face and determining whether we want to narrow the cheeks, or we want to move the eyes back, or we want to do eyelid surgery. But it all has to be set upon with a customized approach, especially to orbital decompression. So a patient from some while ago who had just an orbital decompression. And so you can see the dramatic changes that can be improved within the eyes, but also the eyelids, the puffiness around that can be improved with a decompression if it's done adequately and enough. And this is a more of a single staged approach, but multiple surgeries all done at the same surgery where we move the eyes back some, also got rid of the fat bags underneath the eyes, lowered her eyelids just a little bit because she felt that she was just a little too wide open, and then narrowed her face with the buccal fat removal, which has to be probably one of the, everything I do with the eyes, the buccal fat has to be, people just love it. That has to be the highest satisfaction procedure I probably do. This is just another example. Oh man, just one surgery, both eyes same time, but multiple procedures done, moving the eyes back quite a bit on both sides, about 6 millimeters with the customized decompression. Also releasing the lower eyelids on the upper and the lower, some fat injections to the temple just to kind of smooth things out, especially the cheeks, and then buccal fat to kind of narrow that face, give a little bit more of a masculine facial profile. And again, just another case of very, very asymmetric disease. We decided to operate on both eyes, but very differentially, much more on one side than the other side, a little bit of fat injections through the mid-face, through the cheeks here, right next to the nose, that just to augment that, square off the jaw just a bit with some of the fat injections and really improve. This is a patient who was mine. She was on the doctor's TV show. We did her journey, and her journey's on our YouTube. But she had very bad disease in both eyes. We did a customized decompression, buccal fat removal to narrow the cheeks, fat injections to the mid-face, and a little release of the lower eyelids and a little release of the upper eyelids just to kind of improve things, and really had a remarkable improvement and couldn't be more thrilled. And she's doing quite well. Most of my patients travel in to see me, so I do get great texts all the time to, letting me know how they're doing, and really do appreciate that. I'm going to turn off my screen sharing now and go back to, hopefully taking some of your questions at this point in time. And would like to, I'm going to start to pull them up. I know many people were really great about sending in some questions, and feel free to put your questions in. I'm going to start with the people who sent in some questions first, and then we'll kind of go from there. But please don't be shy, and we'll get you your questions answered since I dig through all my open folders to get them. But one of the things to know is that we can often fix upper, lower eyelids, eyebrows. Many of these things can be done together, whether you have prominent eyes or not. So just don't even think this is all about prominent eyes, but patients with prominent eyes certainly have the hardest by far eyelids to deal with, because they are at a huge risk of having poor surgery. So it is really something that we focus on quite a bit to make sure that those patients don't get into trouble, because it's highly likely that you can have quite severe issues when you have prominent eyes doing any of these types of procedures. So the first question is more about Graves' disease in general, and then we can start. So one of the first questions is, for Graves' disease, what foods need to be avoided? Never get a clear answer. Is coffee bad, meat, fish, etc. I think a great book, and I'm not related to this, but is The Plant Paradox. I think that one thing to really look at in Graves' disease is the association of glutens and the association of dairy and meat. Each of these affect patients different ways. So gluten will almost always, cause bloating and difficulty and even flare of the eye disease. And then after that, everyone kind of has to kind of experiment for themselves. Dairy is also a high likelihood of causing upset. nuts and even nightshades, but it doesn't, not for everyone. So it is one of those things where you almost have to begin to determine how your body feels after each of these foods. I tend to be on a vegetarian vegan diet, no dairy, and a bit of fish, but that's because of health, what I believe are health issues. And that tends to work very well for my patients, especially when they give up dairy, gluten, and really cut down on meat. So I think that that is very, very reasonable. And the book is called Plant Paradox. It's a tough diet, but it really gives you a lot of explanation as to why many of these things are inflammatory, especially because they happen in the gut, where the largest immune system, your largest nervous system exists. And so anytime you're bloated or you're just not feeling well in that way, it's usually affecting your immune system. And then, so second question, will the upper brow fat that accumulated due to Graves' disease go away on its own, or does it have to be surgically fixed? It often has to be surgically fixed. A lot of patients will get this hot dog brow thickening, and it's very, very hard to deal with, frankly. You can do a combination of things to fix it. One is you can remove a little bit of tissue from underneath the brow, but it's very, very hard because it's actually the thickness of the tissue sometimes, and only so much can be removed without making it bumpy and really making it worse. You can also do fat injections around that tissue, because what happens is it almost becomes a hot dog, so you can smooth it out with fat injections all around. And then finally, sometimes you can do a little brow lift. And I saw one question come in, if one brow is lower than the other, can you lift? And sometimes a brow lift to this will spread that tissue out and will actually be very nice. And if there's any asymmetry of the brow, that's often due to facial asymmetry. So it can be due to bony asymmetry, where one side of your face is a little smaller, one side of the orbit is a little smaller or differently shaped. And that usually leads to the brows being different heights. You have to be careful on how to fix that, because since it is an asymmetry of often the bone or soft tissue, you have to kind of fix it that way. Deep fat injections can help to augment that, but sometimes a little temporal brow lift can also be very, very good. You have to be careful with doing too much of a blepharoplasty, just because they can look very hollow, and it doesn't really get rid of the heaviness of the brow, and it can sometimes even pull the brow down. And Botox actually for Graves and non-Graves patients works really well. For my Graves patients, it really helps with the headaches, pain, pressure, especially if you get it in the temples and in the corrugators. And it really helps to get rid of that constant clenching. And it can also really nicely shape an eyebrow as long as you're willing to do it every 3 months for aesthetic reasons. So our next question is a little bit more about Depezza. Now, Depezza, which I've briefly alluded to, has been kind of the rage, because for the last 50 years in thyroid eye disease, we've had nothing for patients to offer them that was new, different, and potentially could reverse the disease. So the introduction of Depezza, especially by virtue that it blocks the receptor that is overexpressed specifically in Graves' disease, is just really exciting. And we're just now beginning to understand potentially how powerful Depezza can be. So what's been shown in the studies, and I have slides, but I think we can kind of work through this. What's been shown with Depezza is that it dramatically reduces the amount of eye bulging that occurs in patients, especially given relatively early in the disease. So when you're thinking about a clinical trial, you have to test somebody, you have to start somewhere, and you have a lot of centers, and so you have to be able to measure stuff and for everyone to agree. And so that's kind of why Depezza was used in this first group of patients, because everyone could agree that they had meaningful thyroid eye disease. We could agree on the timing, we could agree on everything, and figure that that's, kind of a great place to start. Well, it works so well that it was published in the New England Journal not once but twice. So that is an amazing advance where there had been nothing. Now there's actually an FDA-approved treatment for thyroid eye disease, and now it's been kind of going beyond the classification of patients that were chosen for the clinical trial to now focus upon what other patients could this be used. And I think that that's, right now where where things stand is we're really beginning to understand better and better. I am using it, just to be specific and answer some of the questions. I am using it for patients who've had previous orbital decompression. I think it's, you have to always balance the risk and benefit for patients. And also, we have no reason to believe that it doesn't work in patients who've had this disease longer. So, I certainly think that even patients who've been diagnosed with inactive or chronic TED could benefit. It's just under active investigation, though, so I think that you have to be careful and you have to set expectations correctly. And I do this in my web consults, which I do pretty routinely for patients all the time, especially if they want to consider this therapy or come and do it. And I administer this therapy myself, so I watch every patient, almost every infusion, make sure how their side effects are doing and everything, and it's very well controlled, and it's a very easy medication to administer and with very low side effects. And so I think that, it's very reasonable, in a consideration, and as long as you look at the risk and benefit for each patient. And, so I have been anecdotally, just in my practice, I have been seeing benefit for patients who've had this disease for quite some time. And also there's, some recent publications to suggest that is happening. Another question was, how successful is Depezza to treat double vision? Double vision is tough to treat, which then kind of comes back to what else we looked at in the clinical trials. So we also looked at bulging of the eyes, but not only bulging of the eyes, also looked at how well it treats double vision. And it turns out that the double vision is improved in the majority of patients. Now, in many, about half, this is almost back to normal, where their double vision kind of went away completely, but not all. So I think that for double vision, you have to have realistic expectations, knowing that anything we do in surgery or anything always makes double vision worse, never better. But the chance to improve both bulging and double vision now is quite promising. And, so I think for patients who have some degree of double vision, absolutely, it's worth a consideration. It also decreases the inflammation and the puffiness around the eyes, kind of what you saw in some of those in that photo. And that is a pretty dramatic improvement. And frankly, patients really love the treatment, and they don't, in my care, haven't stopped or haven't, wanted to discontinue the treatment, and been very enthusiastic about it in general. So another question, just making sure we cover everybody's. So, which kind of shifts a little bit to orbital decompression. And one of the questions about orbital decompression, I kind of talked a little bit about orbital decompression, just in general, that we're making more room behind the eye. I didn't show any surgical videos. I've done that one time. I started surgical videos and everyone passed out. So I'm not going to show any surgical videos. Those are available. I do have a video textbook about that, but we're not going to go there today. The idea with orbital decompression is that all the scars, so to speak, or the incisions are hidden. They're either hidden in the eyelid crease, which is a tiny scar about 1 inch, or they're all inside the eyelids. And it honestly just depends upon what's best for an individual. Sometimes, a skin incision is required. Sometimes it's not. Sometimes I'm going to lower the eyelids, and we require that anyway. But all the incisions are hidden. As you can see in the patients that I just showed you, I bet that no one could find their incision. I'd be hard pressed. Patients often don't even know where their incision was because it's so well hidden and heals so well. So the chances of having keloids and permanent scars really, really rare on the outside. Now, what does happen and can happen is the risk of double vision. And that is variable. It depends on how large the muscles are. It depends on a variety of variables. I've worked at I do about 250 decompressions per year. So I've worked out a pretty good risk category. The risk is not zero. In some patients, it's 1 to 5%. And in other patients, it may be as high as 20%. The 20% doesn't happen too often, but it can. And so I think you just have to be very realistic, knowing how much decompression you're going to get. The more decompression you do, the higher risk of double vision. But double vision is almost always fixable. And it comes from the scarring inside the orbit, but we can almost always fix it, but it does require different additional surgery. Previously, and I think some of my colleagues still do stage surgery. So it's like, they will do 3, 4, 5 surgeries where I'll do everything at one time. And we found that 95% of the patients only need the one surgery. So I really think that even if we have to go back for double vision, it's a small issue compared to trying to divide multiple surgeries up over many years, which I tend not to do, or don't do, frankly, and I haven't done it for 5 years. And we're trying to publish a paper just to kind of demonstrate that I think that should be the new way of thinking rather than dividing these surgeries up so much. Is there a chance of symptoms of thyroid eye disease coming back after decompression, or should be even after Depezza? The answer is absolutely yes. So patients face a 5 to 7% chance of their thyroid eye disease, so-called reactivating, after this disease has presumably stopped. And it's, what we often see in other autoimmune diseases where there's a relapsing, remitting nature. It doesn't happen very often in thyroid eye disease, especially in non-smokers, only about 5% of the time. Smokers, it's much higher, so avoid smoking. But it does occur, can occur after orbital decompression, and sometimes orbital decompression can even spark it a little bit or increase that likelihood. Also, it can occur after Depezza. I had one patient who received Depezza who had to have another course, did amazing and excellent, got way back to normal, and again was just fine, but those things can happen. And if they do, then I would say that you undertake appropriate medical therapy, and that might be Depezza, that might be steroids. It's unclear. I think it has to be in an individual basis what's available, but usually I would be going for Depezza in those types of patients. But I think every circumstance has to be approached individually. So next question: can the eyes move even a little further back after things have healed after orbital decompression surgery? So I tell patients things are going to change and move back until about 3 to even 6 months in some circumstances. That's when we'll know where the semi-final result is. After that, there are aging changes, which your eye, as you age, you lose fat. And as you lose fat, the eyes fall back and become deeper set. If anyone has like a really old grandparent, you'll know that their eyes look hollow. And that hollowness is from some sagging, but it's also from fat loss. So as people age, their eyes will begin to come back, but that's over a relatively long period of time. And so I usually don't say that that's probably something to look forward to, but it will usually get better, not worse. And then how long does it take for the incision to no longer be swollen from orbital decompression and eyelid retraction? Two different things. From orbital decompression, the incision heals pretty quickly, usually swelling, bruising gone in about 2 to 3 weeks. From an eyelid retraction, sometimes that lid can look swollen, or what's called the platform or the area above the eyelashes can look swollen. It's almost edematous. And sometimes if that, depending on how the surgery is done or what was done, that can last for quite a long time or even be permanent. That would require an individual answer. If it's going on for longer than 6 months, it's a little worrisome that it could last quite a long period of time. Should you continue to do warm and cold compresses a week after orbital decompression help with healing and swelling are no longer necessary? Cold compresses for the first 48 hours really helps to shrink down the bruising, swelling, and then dramatically improves. Warm compresses then can help with the bruising to disappear. You can do warm compresses or cold if they feel good after 48 hours, but not really necessary. Do the eye bags go away? The eye bags have to be targeted during an orbital decompression, and I target those separately. Just by doing the decompression, you saw in one of my patients, their eye bags did go away a bit, but they won't all go away unless you approach the midface, unless you take care of the eye bags or do some fat injections, which I sometimes do a combination of all those things. So I'll be doing a very small amount of all those aesthetic type procedures at the same time as orbital decompression to get the result. to get the aesthetic result. You can't just do an orbital decompression and expect it to, have an aesthetic result. You have to work at it. And it's just like many spices make a meal. It's just, if the only spice you're using is salt, it's going to taste salty. But you want to mix things and make it look very natural, and with technique, and in many of these aesthetic techniques, make it look natural and make it look very, very refined, so that it's not something that you would ever notice. And I don't think you ever noticed, but all those patients had additional procedures besides an orbital decompression that kind of made them go back to the way they looked before. And that's really critical, because we look at old photographs and then we kind of judge how to get there. So I think we're almost done with the Graves questions, and I'm just going to read one more here. Why is one eye more affected than the other in Graves' disease? We don't know. It's often the case. We often see a lot of asymmetry. Patients hate asymmetry. It's hard to correct surgically. Depezza does a good job of improving that asymmetry. It only works on the more bulging eye, or works predominantly on the more bulging eye, but we don't know the reason. We think it may have some involvement of the immune system or even the sinuses, but honestly, it's hand waving. We just don't understand. And if Depezza is available in Europe? The Depezza is not available in Europe at this time. The trials were done in Europe, but Depezza is currently not available in Europe, as we know, and hopefully that will change in the future. But right now, that is the situation. So a little bit about eyelid drooping, which is called ptosis. So ptosis and lid retraction are kind of combined into one. And that's where we start to really look at the eyelid format. And so I'm going to pull up a photo or two now, especially, and share my screen again, because I think it's going to show us that we can see eyelid retraction and ptosis all in the same bit. So in this patient, you can see that we have on the right, her right side is eyelid retraction because the eye is bulging out. On the left side, the upper eyelid is drooping, and it almost looks like it's too low. Well, if I told you that I only fix the right side eyelid, because once you fix the right side, then your brain raises up the other side. When your eyelid is too high or retracted, the brain kind of relaxes and lets that other eye fall down. That becomes ptotic. But if you lower the other side, often the other side will come up. Now, the opposite can also occur. So if one eye is droopier than the other, you raise it, sometimes the other eyelid comes down because your brain relaxes. And frankly, it's just kind of part of knowing how to do the surgery and how to measure this. You can usually use a drop in the office, but you can do other things to help to, make that better or to assess that. But normally I can raise or lower the eyelids pretty consistently. We can do it underneath the eyelid and shorten the muscle. The hardest thing is not getting the eyelid up, it's getting the symmetry between the two. And that's where we have to work at it. And patients with Graves' disease have this scar tissue that pulls the eye up. And so that's much harder to deal with. Now, Botox has been suggested as a temporary treatment. I tend not to use it too much because it'll either make the one eye go down too much or too little. You can try it for a while, but it's not something that is a long-term solution. When can you go back to work after eyelid or ptosis surgery, and any pain meds after eyelid or ptosis surgery? Well, when you have a droopy eyelid and we raise it, there's not a lot of pain associated with that. It might be a little scratchy feeling, a little swollen. But usually I say, you may want to work from home for a day or two, which is pretty easy right at this moment in time. But just only because there's a little bit of swelling and your vision may be a tiny bit blurred, but there's not a lot of pain or discomfort associated with it. And so as long as you don't mind there being, someone noticing that there's swelling, usually you can go back to work pretty quickly. No heavy exercise for 2 weeks because that can cause the eyelid lower, no heavy rubbing, exercise that would, entail hitting the eye or anything else like that. So it's something you just have to be careful with for 2 weeks, but you don't have to take anything off. Do you need to lower both eyelids, even if it's only one eyelid that's retracted? Maybe. If one eyelid comes down, then the other, as we said, may come up. So if they're both high, maybe you lower one and the other one comes up. It honestly depends. Sometimes that is very tricky, and either raising or lowering one or both is something you only can kind of tell with an in-office test. Sometimes we can add a drop to tell whether we should raise or lower one eye. And it's, one of those things where you just kind of have to be flexible, but it does usually require an in-person exam. Now you can prepare that, but in advance and talk about it. And it's not that hard to do surgery on one or two eyes. It's just that you just have to, kind of approach that in person, at the time of preparing for surgery. So I do recommend any scar gel after orbital decompression or eyelid retraction surgery. The scars, eyelid retraction surgery is often done from the inside, and I said the scar is usually not a problem. I only use the one in the eyelid or inside the eyelids. I've never had to use scar gel, and I've never had a patient to actually complain about the scar. So I'm always kind of shocked to know that patients have scars after the surgery, because none of the techniques I use really have ever generated. Eyelashes have changed direction due to Graves' disease, and thanks to the eyelid retraction, and they don't curl up. This is actually something that has been told to me in the past, and I do agree. I think it's probably due to the eyelid retraction. Sometimes when you fix the eyelid retraction or the orbital decompression by moving the eyes back, it will sometimes make that better. Doesn't always. We can always do an eyelash lift, meaning I can make a little incision and kind of lift the eyelashes and point them. It doesn't make them curl, but it makes them at least lift up into the right direction. Not an easy problem, but usually it gets much better with the eyelid retraction surgery because you're releasing the muscle. It's kind of curling those eyelashes in. When you release that, it usually allows the eyelashes to go back. It's usually not a permanent issue. Is recovering from twilight anesthesia better than general anesthesia? So I love this question because I get so many questions and people are so worried about general anesthesia, which I agree. But there's various things to know about general anesthesia. Not all general anesthesia is the same. So I use mostly what's called an LMA, or a laryngeal mask anesthesia, on all the appropriate patients, which is the majority of my patients. What this allows you to do is almost be under the same type of anesthesia as twilight, the IV anesthesia, and the mask just protects your airway. So it's not going past your vocal cords. You don't have to be paralyzed or anything. You're breathing on your own. So it's a safe way of doing it. It's great for these types of surgeries, short surgeries. And because I do everything at one time, you're not having repeated anesthesia. And that's often where you get most problems, is undergoing anesthesia again and again. We do everything usually in about 2.5 hours in one surgery. So anesthesia is usually pretty fast to recover from, especially when you're doing it via this LMA, and you just require less anesthesia, and it's almost IV. We're almost getting to our time, so just another question or two. And the question was, I had a lower eyelid lift and looked better for a little while, then got worse. It can be fixed without recurrence. Depends on what looked better. A lot of times what happens is that someone will remove a little bit of fat from the lower eyelid, and then what happens, you age and the fat kind of comes forward again. It depends on over the time period. Sometimes that's not fat, and sometimes it's even swelling. So this occurs a lot after filler, where you get these abnormal fluid pouches. Usually if it usually is not something where the lower eyelids come back. You should expect a fairly long lasting result from lower eyelid surgery. Not lifelong, but usually many, many years of an improvement and a reversal of the aging, especially if there's a little skin removed or other things. So individual circumstances all vary, but I'd be looking for whether that's really fat or fluid coming back. And B, there should be things to actually do. Usually lower eyelid surgery is a relatively long-lasting improvement for this. Well, it's kind of almost coming to the time where we've gone through everyone's questions, given you a little lecture and a little demonstration. One of the things we'd like to do in the future is to make these, more common. We'd love to know what kind of questions or subjects and topics. I have probably literally 1,000 different lectures, because I lecture all over the world, and happy to discuss not just Graves, but any aspect of eyelid surgery or skin cancers or aesthetic surgery. I do a lot of aesthetic surgery, especially even in Graves patients, but how it might be different or what you might be looking for. What is a brow lift? So any questions that you have along the way, happy to, to facilitate them. We also do video consults, which I do quite a bit, and usually screen all of our patients either for medical or surgical therapy, and then they come in for surgery, and usually stay in Los Angeles for about 7 days. So we're always happy to facilitate those, and make sure that people have all the information that they need moving forward. But greatly appreciate everyone's attendance, and greatly appreciate Marcy for bringing me into the technological world and helping me here to make this possible. And just one other question: can a 13-year-old use Depezza? Probably not. We're waiting for it. It hasn't been used in patients under 18. We definitely want them to get through their growth curve before using Depezza. That would be an off indication usage. It would require a lot of thought and careful attention to consider something like that. But thank you all, and I hope you have a great rest of the day. And please visit our website and YouTube page. And happy to we'll have this recorded, and we have many videos of lectures and other things, and just little vignettes. So whatever you need, we're here to help you. Thanks so much.